Hello and welcome, welcome, welcome. This is our uh, live chat on patient information, which, of course, if you're working in health information management, this is kind of it, okay? But this is we're going to just talk about a few things that you really, really should know. Okay, so let's talk about the highlights. Oops, it's not going to work that way, so we'll go this way. Okay, so first, to clarify, I know that you probably heard the term third-party payer, and that is a generic categorization. And the reason why we talk about the third party payer. Of course, the first person is the physician, and the second person is the patient. And you may read and see it the other way around because it's hard to tell. But without these two components, the patient and the physician and the patient, we don't have an encounter. So, but the reason we're talking about this is the third party payer concept. And it is a generic term referring to someone who pays for the provision of these services from the healthcare provider to the patient who is not involved in the encounter. So, not the physician and not the patient, somebody else. Now, most often, this somebody else is a healthcare insurance plan company. Okay. So you might say, well, why don't we just say the insurance company? And that's because we in the United States also have Medicare, Medicaid, TRICARE as examples of third-party payers who are not insurance companies. Medicare, and I know some people wrongly think Medicare is an insurance policy or it's insurance coverage. It's not insurance. And if any of you would like to just take a quick peek at your pay stub, you'll notice that it's not a gift at all. It's something you've been paying into from every single paycheck you've ever received. Okay. It is a government program that provides payment for healthcare services to the patient, the beneficiary. Okay. So that's why we use third party payer to be inclusive of Medicare, Medicaid, TRICARE that are not health insurance companies or health insurance plans, but they do pay for healthcare services to be provided to the individual of interest. Okay? Does that make sense? All right. So also note that depending, you might have a third party payer who is the parent of the patient or a spouse of the patient or a guardian of the patient. Okay. They all are considered third party payers because it's not the physician who's paying and it's not the patient who's paying. Okay. That's easy for you to understand. Okay. Now, another thing that we come across, especially when it comes to CPT coding, which is reporting of outpatient services and physician services in any location. All right. And that's to understand the difference between a new patient and an established patient. And the line is 3 years. Okay. So if we have somebody who has not been seen by this physician, asterisk, within the last 3 years, they are considered a new patient. If they have, then they're considered an established patient. The asterisk refers to, and this is how the American Medical Association defines this same provider, is an individual provider. So, it's typically a physician, but it could be a nurse practitioner, a member of the same group practice with the same specialty or subspecialty. Now, you might say, what's the big deal? So I'm going to tell you, and then you're going to know. How exciting is that? Okay, so the deal is this. The established patient already has encounter notes, patient history, and all kinds of information about this patient before today, before this encounter, that this physician can read and catch up on and know what's going on with this patient, whereas a new patient is, I don't know anything, right? Now, you may say, well, why does it have to be the same specialty or subspecialty? And that is because there are large physician groups who have different specialties under the same roof, okay? So the reason for the specification about the specialty and subspecialty is because a physician who specializes in a particular specialty may want more detail or information about the history of the patient with regard to this specific body system or this specific diagnosis that another physician might not spend that much time with. Okay, so that means, all right, so you're an established established patient of a primary care physician who says, you know what, I'm concerned about your blood work with regard to your thyroid. So I'm going to refer you to my partner who is an endocrinologist. Okay. So because they're partners, there's going to be all of the notes that this primary care physician has taken, all the results of the lab work and any imaging and the whole kit and caboodle about this patient, okay? However, the endocrinologist may need to ask more questions, investigate further solely with regard to the patient's endocrine system and specifically their thyroid. So this specialist may have to, in regard to this, spend more time in ferreting out this information during the encounter. So this enables this physician, this specialist, to get paid more for this encounter because not all of the detail about this patient's condition is there already in the notes. Does that make sense? Email me if it doesn't. You got to think about this for a while. Okay, so as we continue to talk about the relationship between the provider, the physician, and the patient, okay, so we talked about new and established. Now we're also going to talk about referral or consultation. And this can be a little bit of a challenge, again, depending upon who you will be working for once you get there. Or maybe you're already there, okay? But these are very two different aspects of this relationship between the physician, the provider, and the patient, okay? So these two are kind of similar mostly because of the confusion comes from the way the common phrasing is in the office. I mean, I'm not even talking about the patient's terms, words, but I'm talking about the physician or the office terms, words. Okay. So a referral is a physician who refers the patient typically to a specialist. Okay. And that specialist is going to take over the full care of the patient for that specific thing. So if you think about the example that I just gave you about the primary care physician sending the patient to the endocrinologist, okay, about the thyroid, that endocrinologist will take care of the patient's thyroid and all aspects due to the endocrinology system of the patient. And the primary care physician will still be the primary care physician and watch over all the rest of the systems, the body systems. Okay? So that is a transfer of care for that particular body system. Okay? The physician says, you need somebody to pay more attention to this. That is a transfer of care. All right. A consultation is a one-time opinion. Okay. So let's say the patient is seeing an oncologist. Oncologists specialize in the care of patients who have malignant neoplasms, cancer. Okay. All right. So now this oncologist gets back the test results, whatever the tests were, maybe a biopsy, maybe blood work or whatever. And the oncologist says, you need to have surgery to remove this. But it is always, always smart before having surgery, particularly major surgery, to get a second opinion. And I'm sure you've heard that term, right? You get a second opinion. Let's see what this other oncologist thinks about my test results. Okay. The patient goes to see that second oncologist with all of their test results. The second oncologist says, yes, no, maybe, writes it in a report, sends that to the first physician. And the patient goes back to the first physician. So the relationship between the patient and the second opinion is a one-time only thing. There's no long-lasting relationship. So that is reported in coding as a consultation, as opposed to transfer of care, which would then be reported as a new patient and then ultimately established patient. Okay. So these details have to do mostly with your understanding of the use of these terms and how they affect, how they result in, thank you, thesaurus. Okay. All right. And this is why they don't let me teach English. All right. So this is why coders, medical coding professionals have to be smart. And this is why you had to take medical terminology. But this is not medical terminology. These are regular English words. But still, you got to know the difference. And you got to be able to tell the difference from the documentation, because you already know if it's not documented, it didn't happen. And if it didn't happen, you can't possibly assign a code to it. Right? Right. Okay. Look how smart you all are getting. All right. Now we have another phrase commonly used in doctor's offices, but also in hospitals, of course, when a patient is being admitted. One of the first things, when the patient makes an appointment, mostly in outpatient, okay, there is a process that is done behind the scenes. The patient doesn't really know about this, but it's called eligibility and verification. And it's simply, and it's all done online now, okay, but it's simply for the physician's office to contact the third-party payer that this patient says they're covered under to make certain that their coverage is current. Okay. No, it didn't end at the end of December, and now we're in January and you don't got no insurance, but you're trying to fool me by showing me your old insurance card. It happens. okay? And two, to verify that the patient has this type of coverage, okay? So, for example, I'm just going to use Medicare, okay? Medicare, you may be familiar with Part A Medicare, which covers inpatient. There are also private insurance policies that are called major medical, okay? And basically, those policies only cover major healthcare events like surgery in a hospital or being admitted into a hospital, but they don't cover going to the doctor for a checkup or going to the doctor for an allergy shot or a flu shot or anything like that, okay? So we have to find out, the office personnel of the physician's office or the hospital, okay, we have to find out, do you have current valid health insurance, and does it cover this type of service? Admission into the hospital, a flu shot at the doctor's office, whatever it might be, okay? Now, outpatient, well, also inpatient, if the patient is being scheduled to be admitted, proper protocol is to do this prior to the encounter appointment, okay? And this is why, true story, okay, yes, I was a Girl Scout, okay, true story. A couple of years ago, I made an appointment with an allergist. I needed a new allergist and I needed to start allergy shots or whatever. So I made an appointment with this brand new allergist to do the whole battery of allergy testing and everything in December. Okay. And this is such a wonderful example of how good it is when you do your job properly. Okay, so I get a phone call the week before my appointment, and the young lady who was calling me from the doctor's office said, "I just want to tell you something, that your appointment on December 15th, right now, you have not met your deductible for the year. So you're going to have to pay, you would have to pay out of pocket $500 for this appointment and the tests and everything. However, if you wait until January, you're still going to have to pay the $500 because you got a brand new deductible starting in January. But it will count for the whole rest of the following year, as opposed to meeting the deductible. Great, my annual deductible, which ends 2 weeks later." So I thanked her very much and I rescheduled my appointment for January. Okay. But do you see how helpful that was? How great that was? She did her homework on eligibility and verification, and she helped me by giving me a full 12-month value to my $500 cash deductible versus 2 weeks. Now, don't you think your patients deserve that? So as soon as the appointment is made, when it's made in advance, eligibility and verification should be the proper protocol in your office, wherever you're working, to do that as soon as possible. This will also help you confirm what the patient's copay is or coinsurance, anything that they have to pay the day they come in for their appointment. Because again, that's the right thing to do for both the physician's office, the healthcare facility, as well as courtesy for the patient, right? I think so. All right. Now, another thing that you need to know about additional information that we are looking to collect, whether it's on that new patient information form, you know that form, the forms you have to fill out before you go the first time. Okay. Or maybe it's an update, especially this is January. A lot of physicians' offices will have patients confirm or fill out a new patient history form or something like that for the new year. Okay. But these are 5 areas of regular life that directly and have been found to be directly involved with an individual's health. They directly impact an individual's health. Economic stability, just as an example, I'm just going to give you examples off the top of my head, but economic stability, if a person does not have, a regular job, which gives them a regular income, they may not eat regularly, or if they are low income, they may not be able to afford healthy food. And, we all know this, and I have no idea how to fix it. I guess nobody else does either. But fresh fruits and vegetables in the produce department of the grocery store are much more expensive than the can of green beans or a can of corn that are found on the shelves. Now, canned green beans and corn are still healthy food, okay? But it turns out that, beanie weenie is really inexpensive, okay? So economic stability and making sure people have enough food, enough money to buy food, okay? It also comes into play that in order to maintain good health, you must have a safe place to live. You must have shelter. Okay. So that's a big part of promoting good health. And if any of you have interest in public health, these are really, really important aspects. And they also have codes to report this so that we can do more statistics about it. Okay. And there are lots of programs to get like fresh produce and things in the hands of those who can't afford it at the supermarket. Okay, like farmers markets is a whole thing. If you have questions, email me. Okay. All right. Education. And education is more available now than it ever has been before. And this right here, right? Online. I don't have to get a babysitter. I don't have to take time off from work. I can watch this at 1 o'clock in the morning if I want. Okay. However, the better the education of the individual, the better lifestyle they can have. Of course, then, higher education leads to higher income, job security, economic stability. Thank you very much. And that has been a fact of life forever. Okay. And I know I'm preaching to the choir because here you are in college classes. That's very good. Okay. And but there are so many people who do not take advantage. Either they're convinced that they're not smart enough, or they're convinced they don't have the money, or they don't have the time, or I'm going to write a book on excuses because I hear way too many of them. But the point is that it is a fact that has been documented for hundreds of years. The better education, the higher education, the better job, the higher income, and that all goes back right to making sure you have a safe place to live and good healthy food to eat, and you can't live on beanie weenie or McDonald's. I mean, I love McDonald's. I really do. But as a treat, I know that's a bad thing to say. Still, you already know what I'm saying. Okay, social and community context. And I guess we've all learned over the last 3 years with COVID lockdown and everything, and how our social ability has been displaced, it has been damaged, it has just been and we see this resulting in greater issues of mental health. Okay, in addition, that mental health can then, and let's just talk about the easy one, depression. Okay, and when you're depressed, most people tend to either not eat or eat too much. And trust me when I say the eating too much is not green beans and corn. It's eating too much of the bad things, because there's something in our wiring that says, you know what, I'm feeling very sad. And I know the cure for sadness is cookies. It'll make me happy, right? Yeah. Okay. So we all know that big circle. All right. Health and healthcare, and this has to do with accessibility to healthcare. And this also, over the last decade, has been dramatically increased. We have more walk-in clinics. We have more opportunities in neighborhood healthcare. Plus, we have the marketplace, which provides the ability for an individual who does not have the opportunity to get insurance through their employment. They can get insurance directly through the marketplace with policies as low as free or $10 a month. I mean, it's amazing. Okay. But now we're going to go back to the second bullet, because there are a lot of people that don't know that. And if you're not educated to know that you can go to the marketplace and get health insurance for as little as $10 a month, or maybe even free, then you're not even going to go type it in and Google it and go there and find out what you can do for you and your family. So you need to be educated about the opportunities. You need to be educated about the free clinic down the block, or the walk-in clinic that doesn't require you to have insurance, or what. If you don't know, how could you possibly do it? All right. And then, of course, neighborhood and built environment, and that refers to the quality of the buildings as well as the building materials. Okay. Um, Old construction, old. And if you're living in a place such as New York City, there are areas in New York City where there are apartment buildings that were built in the early 1900s. Okay. When they did not know lead paint was bad. Okay. When they did not know asbestos was bad. Now, efforts have gone in to clean out asbestos from old buildings and to make sure that lead paint is gone. But is it 100%? Not necessarily. Are there other building materials that might be in the walls and the ceiling that could hurt? I don't know. Okay. And then we also have improper building materials. A step breaks, they don't fix it, which increases the opportunity for injury. And are we going to talk about insects? Because I don't want to talk about insects because they're in rats and ew. Okay. But the fact of the matter is, you talk about you talk about rat infested tenements, and it sounds like something from a TV show or a movie. But the fact of the matter is this is America, and these places do exist. Okay. So again, let's go back to education, where people need to know that that's wrong. They need to know to whom to complain, the building department, to get something done. Okay. To get something fixed. But again, generally speaking, the people who are living in these places tend to be less educated, so they don't know. So we need to tell them, okay? Because it's in all our interest to have a healthy community, a healthy city, a healthy state, a healthy America, okay? And we can all contribute to this, whether it's education or volunteering or whatever. But we're going to start with collecting the data from our patients so it can be coded and reported so that the statistics, the research can be done. Okay, we as health information management professionals contribute to this just by doing our jobs. And maybe this requires a discussion with the intake nurse or the physician or whomever to make sure these details are being documented so they can be coded, so they can be collected and analyzed, so we can get more funding for fixing these decrepit buildings and living environments and getting more neighborhood clinics and helping people get to the marketplace so they have insurance and getting people more education so they can get better jobs. You see how it's all rolled into one, and it all includes the ultimate benefit of better health. Okay. More to come. All right, PHI, protected health information. This is HIPAA. This is what is governed by HIPAA. This is any information that can be linked back to a specific person, a patient identifiable health information. Okay, I know in your law and ethics class, you should learn all about these details, but you need to know when to keep your mouth shut, which is like all the time. Okay, except we're going to talk about use and disclosure. And, you know, I mentioned before about the fact that you had to take medical terminology because you have to understand the physician documentation. But in addition to this, we sometimes use regular English words, but we use them in a very different way. So this is use as in the sharing of information between people working at the same healthcare facility for purposes of caring for the patient. Okay, so I'm an HIM. I need to talk to the nurse. I need to talk to the physician. I need to whatever that's within our facility. That's okay. All right, as long as I'm doing it in a protected private environment. Disclosure is sharing information about a particular patient with other places. Okay, do we do this? Yes. Okay, because when the physician writes an order for the patient to go get blood work and they're going to go somewhere else to the lab to get the blood work done, there's an order printed out. And you know what's on that order? Patient information. You know what? Protected patient information. You know why? Because the patient's name is right at the top, and there has to be a diagnosis to support the medical necessity for the blood work. So the whole ball of wax is right on this one piece of paper. Okay, or email or whatever. But the point is that is disclosing. I have to tell the lab why this patient, this specific patient, requires this particular test. That is disclosing information because we're not in the same office. Okay. So other than that, keep your big fat mouth shut. All right. Now, we also have to get informed consent from our patients. Now, when it's for something such as surgery, informed consent needs to be a discussion between physician and patient. Okay. However, we also tend to be the ones, or the nurses or medical assistants need to be the ones to get the patient to sign informed consent. And you also need to know about informed consent for use and disclosure. Okay, so there are two types of informed consent. The first is express. Express consent is, here is a form. The form states that you patient are giving us permission to tell the lab, or to tell your insurance company, or to tell whomever exactly what, why, who, where. Okay, and then the patient signs it. Could be ink, it could be electronic, doesn't matter. It's in writing. Excuse me, in writing. Implied consent is typically conveyed through a patient's actions or conduct. So what that means is a patient comes to the doctor's office, they are led to the exam room, they go into the exam room, they get into the little paper dress. That implies consent for an examination, or to have a discussion with the physician or the nurse practitioner. Okay, so that is implied from my behavior, as opposed to express consent, which is done in writing, no two questions about it. Okay, so in this case, express does not mean fast, it means undeniable. Okay. All right. Now, informed consent requires specific components. And this is very important because, again, we in health information management are the keepers of the documentation. And this is documentation that must be express. It must be in writing that this was discussed with the patient, and then the patient is going to sign off on it. Okay, this explains the procedure, what is being recommended, and its benefits regarding the diagnosis. This is going to cure you, this is not going to cure you, but it's going to make it better, things like that. Okay, and then two, explain the risks of the procedure. Okay, number one, if it needs general anesthesia, you could die. All right, but you could die crossing the street. Whatever else possible could go wrong. This is required. The only way the patient can make an informed decision. Okay. Explain the benefits and risks of not having the procedure. Okay, so patient, if you say no to this procedure, here's what could happen. Okay. Explain alternate treatments such as medication. Instead of having the surgery, we can put you on this medication. You can try acupuncture. You can try chiropractics. You could, whatever. Okay, they're entitled to know. All right. Confirm the patient's ability to understand this information and make a decision. Okay. And then the conversation between physician and patient must be documented and signed off on by the patient, because it's evidence, it's proof that we did our jobs. Okay. And then one last thing I want to tell you about, which interestingly, I teach another class, and this came up, and I was shocked at how many people who are currently working in healthcare do not know about super confidential. Super confidential patient information includes substance abuse, documented, and or any treatment. A patient who is positive for HIV or positive for AIDS, which is a manifestation of HIV, and psychotherapy notes. Okay, these are only released with the patient's express written permission. And with regard to psychotherapy notes, typically you have to get the psychotherapist to agree to release that information as well. This is all described in HIPAA, but you need to know that substance abuse, HIV status, AIDS status, and psychotherapy notes are not included under the general HIPAA guidelines for use and disclosure, mostly disclosure. Okay. And I think you can see by the topics at hand that this is, you need to specifically ask the patient, is it okay? Okay. All right. Have a wonderful day. Have a wonderful week. And please, please, please email me if you have a question, if you want to conversate about something. I know that's not a word. And if you just want to learn more, or if you want to confirm that you're understanding properly or anything, whatever it is, I'm here for you. And I love it when students ask questions. Okay, have a super fantastic day, week,